Hello, Sarah McCune. My name is Rachyl Pines, and now it's Dr. Rachyl Pines, and that's thanks to you and the fellowship that I was awarded. I really can't tell you how much I appreciate it, so I've prepared a brief presentation for you to show you what I've been working on for the last year. So I'm just going to share my screen with you now and take you to this PowerPoint presentation that I've put together. Okay, so as you can see, the title of my work is Managing Patient Aggression in Healthcare, a Training of Competent Accommodation to Prevent Workplace Violence. So a little bit about workplace violence. In healthcare, workplace violence is incredibly common. Some studies have shown that people experience it up to once a day in emergency departments, which is super high. It's also associated with unfavorable outcomes for staff, including things like high turnover, low feelings of confidence in your job, really high job stress, and even absenteeism, not wanting to show up because of how much you don't want to deal with this problem. One example of a story that a participant told me in my research is the following. A psychotic patient threatened to kill me and my family. It was like he was reading from a script, totally deadpan. So I think you can see here that this stuff is really serious and it's really scary for staff. So with my research, I wanted to understand what orientations or attitudes staff hold toward aggression management. And I wanted to develop a replicable, theoretically driven training for health staff. And finally, I wanted to find out what communication strategies work to reduce workplace violence and de-escalate patient aggression. So I did this across 2 studies. Study 1 tested interpersonal skills at a hospital in Central California, and Study 2 trained intergroup orientations for staff at a clinic in Central California. In order to prepare for these studies, I used the time that I had freed up from the fellowship that you all awarded me to conduct pilot interviews with nurses in Australia. And I also spent a lot of time, not only in the last year, but the years before that, volunteering. I spent a year volunteering in the emergency department and a year volunteering in the neonatal ICU because it was really important to me that this work was relevant for staff and I wasn't just some scholar that came and told them what to do. I really wanted some firsthand experience. So in order to conduct these 2 trainings, they were similar. Both of them had staff sit in on approximately 1-hour trainings that were focused on communication. So I conducted the trainings at the hospital in December 2018. It was across 8 trainings with unique staff in each. And then for the clinics, I conducted the training in June. In both of them, they had a role play practice scenario. They learned some things that I taught them, some communication skills, and then they practiced those again. And we came back together to discuss what they had learned and what other things they were still wondering about. Both of them collected mixed methods surveys. For the hospital, I sent out a survey 3 months later. And for the clinic, I had them fill out a survey pre, post, and 3 months later. Participants from the hospital were 73 intake staff. So anyone who performs registration, like asking you for your home address and things like that when you come into a hospital. Participants at the clinics were 43 employees across all departments. So this included dentistry, mental health, and primary care. And also anyone in admin. That was actually the biggest piece of the sample from the clinics. So in Study 1, which was at the hospital, I found that 3 months later, staff reported using the de-escalation strategies that I taught them. I also found that they were still identifying indicators of patient aggression more often, so they were ready to use their new communication strategies. They made external attributions for patient aggression. This is perhaps one of my most important findings. When staff blamed external circumstances for why patients were being aggressive, they were much more likely to tap into the new communication skills that I taught them and be successful in de-escalation. And lastly, I found results in the expected direction such that the more they used de-escalation strategies, the more efficacy they felt or confidence in their job, the more job satisfaction they felt, and less job stress. In terms of attitudes toward patients, I learned that those that held an acknowledging approach had the highest levels of efficacy and job satisfaction and the lowest levels of stress and workplace violence. For example, one participant told me that they approach patients in a calm but consistent manner, providing listening presence and acknowledging their feelings and concerns. This was in opposition to like a zero tolerance approach where some participants thought that they should be able to dismiss aggressive patients from the clinic and refuse service. For Study 2, I found some different results. The main finding from study 2 was that the more staff accommodated patients by using more communication strategies that I taught them, the higher success they had in de-escalating patient aggression. And those communication strategies were intertwined. So I couldn't point you to a single one that was the most important. Instead, it was that they used more was the most important part. In terms of staff attitudes, the training significantly improved staff attitudes toward patient aggression. So they were more likely to hold that acknowledging approach that I just told you about in study 1. And those better attitudes meant that they were more likely to use that accommodation or those skills that I taught them in the training. I also learned that the more they accommodated patients, the more desirable their outcomes. So more accommodation meant higher job satisfaction, higher self-efficacy, more patient cooperation, and less job stress, which was a really exciting finding. So my results from these 2 studies that I've just briefly shared with you hold some really important theoretical and practical implications. In terms of theory, I learned that it's not really possible to separate out the communication accommodation theory strategies that I taught these participants. As I just mentioned before, those strategies are intertwined in the applied setting. So if we were running an experiment or doing a vignette study, then it may have been possible to separate them out, and it may have been useful to do so. But when we're talking about this applied and intervention space, it's not useful to separate out strategies, and instead we should be encouraging people to use all of them. I also was able to update communication accommodation theory principles based on my findings to include a higher focus on norms in a conversation and more focus on conversational goal attainment rather than just subjective ratings of the other speaker or satisfaction with the conversation. I also supported that communication accommodation theory is useful for interventions. They've done this a bit in healthcare already in other spaces like pharmacy and patient interactions, but I've supported here that it could be very useful when we're thinking about workplace violence. In terms of practical takeaways, I learned just how important it is for the researcher to be present in the location that he or she is doing the work prior to doing the intervention. So again, thank you so much for this fellowship that allowed me to have the free time to spend several days in every clinic to go and perform informal interviews with staff to make sure that this training was useful for them and to be able to conduct those trainings, which took quite a bit of time. I'm so grateful to have that time freedom. I learned just how important it is to also train front desk staff. Most workplace violence happens in the front desk or waiting area, and so front desk staff need the most attention here, and they often actually receive the least attention. I also learned that training can help improve norms in the clinic. So I have a little quote down here. One participant said, after the training, that they now encourage others to listen to patients and try to understand why they are frustrated. So it's really useful to help encourage listening and those external attributions. All in all, I learned that it's very important to focus on approach or attitudes much more than it is to focus on those micro communication skills. It's not very useful to tell someone, oh, well, don't cross your arms, and then, they won't get aggressive. Instead, it was useful to talk to them about how they approach a patient, what their attitude to the overall interaction is. I also learned that you can train people too much. So some of the people who had prior training in my sample, this actually backfired for them. So we need to find a delicate balance of how much training is too much training. But lastly, and perhaps again, most importantly, accommodation works. The communication strategies that I taught them worked to lessen workplace violence in these 2 locations of healthcare. So again, I just want to say thank you so much. And you and all of these people on this screen really helped me to complete this project. And I wouldn't be Dr. Pines without you and your support. And I'm really grateful again. Thanks. So with that, I'll just say goodbye. And again, I really appreciate your support for our department and for me especially.